Today on Oncology for the Inquisitive Mind, we have a live episode with Dr. Massimo Cristofanilli, MD, a board-certified medical oncologist well known for his research, extensive experience as a clinician and physician, and a leader in the field of breast cancer, and all-round nice guy. Dr. Cristofanilli is sitting with us here today in sunny Melbourne, where we aim to explore his vast repertoire of knowledge on all things cancer, including liquid biopsies, ctDNA, and inflammatory breast cancer. Dr. Cristofanilli serves as the Director of Breast Medical Oncology, Associate Director of Precision Oncology at the Meyer Cancer Center, MCC, and the co-leader of the MCC Breast Cancer Disease Management Team, along with the Scientific Director of the Englander Institute of Precision Medicine, EIPM. Normally, we send a detailed agenda of all our questions to our interviewees, but given that your CV is so big, can only mean one thing, that he is Batman on cancer research, because you definitely never sleep. Thank you so much for coming on the show.
Thank you for having me, Josh.
We are a people-focused podcast. We do like to get a sense of the origin story. We like to get a sense of you as a person. So you are our very first Italian guest. We would love to hear about your journey into medicine. What actually brought you to medicine and then medical oncology?
Thank you for asking these questions. Of course, everybody has a personal history, especially when you talk about medical oncology. So I started to do medicine at the University La Sapienza in Rome. Just after that, my father got bladder cancer. And at that time, there was not much treatments. Chemotherapy was just at the beginning for the form of cancer. So I lost him in a short period of time. But what I saw around me was the lack of research, the lack of resources, and the lack of support in a system that was obviously, as you know, social medicine in Italy at that time. So I got motivated to really get into the field. At that time, I didn't know that I was going to do breast cancer. In a way, I would say lucky to open doors that normally will not be opened. And to be in a world where a famous at that time Italian medical oncologist focused on breast cancer was directing a new department. So I was working very close with him and got trained. He was a great mentor. And interesting enough, during my fellowship, I also tried to spend some time in the lab because I realized that the research was the only way that will actually advance oncology. But you need to combine the clinical experience in the lab. And one day I figured out that that was not possible where I was being trained. So I started to think about how could I go elsewhere. And the only place that makes sense is actually the US. So there was a lot of work in trying to, like you can imagine, the training, the exams, find the position, get a visa, and move to the US. And that was just without looking back. Say, I'm going to the US, I'm going to try to really follow my dreams. That would be to do research. At that time, I already knew that I was going to do breast cancer because I was also working in a practice before moving in Rome, doing breast cancer primarily, but also general oncology. So here I land in New York to do a residency in Department of Medicine at Cabrini Hospital at that time in Manhattan. It was full of HIV cases. It was the early 90s. So here we have medicine is infectious disease. As you know, we went back to infectious disease just recently. Obviously, I'm doing my training in medicine, but we'll never stop thinking about what I'm going to do my fellowship. So continue to apply, send applications. I was lucky enough, again, sometimes you need a little bit of luck to land at MD Anderson, the #1 cancer center in the country. And from there, I think I would just start working hard. During my fellowship, I was also in the lab, one of the scientists that discovered HER2 in Boston. So I was working on cell lines, experiments. While working on cell lines, I figured, why don't we look for cancer cells in the blood of patients? Because I think that would be very important. So by the time I finished my fellowship, I start my position as a attending physician. I already had work on the design of the clinical trial that you may or may not know. It was the first CTC liquid biopsy paper published then in 2004. So from one thing to another, what drives the resistance in the patient with CTCs? Can we improve treatments for these patients? How do we get into the treatment of patients with aggressive disease, particularly hormone receptor positive? But what was going on at the same time? I didn't sleep. During my clinical activity, I got interested in inflammatory breast cancer. That is definitely the most aggressive and still not fully recognized type of invasive disease with the breast, with a short survival, aggressive features, doesn't respond completely to the standard therapy, and present in an unusual way. I didn't know what else we could do till one day while I was taking care of a very young woman, 24 years old, married, coming from Florida with metastatic disease shortly after her wedding. I figured out that we were not doing enough. And, in 12 months, she was gone. I promised her that I was going to start a center, a clinic, a research center for inflammatory breast cancer. This was the Morgan Welch Inflammatory Breast Cancer, the first clinic at MD Anderson, with a dedication not to a donor, but to a patient with the disease. A number of circumstances work in our favor because we had a group of advocates that was really pushing me to do that. So they were able to find funds from the New Mexico legislation. Now we are a New Mexico Senate that wants to give money to the IBC Center in Texas. And of course, they went also to the Texas Senate. They provide $2 million here for funding for the inflammatory breast cancer program. In that moment, the center was born. And how do we really organize this center? We organize this center with different specialties, of course, working on this. So define criteria for diagnosis, how you stage the patients, start to work with the industry for new clinical trials. We had a registry study that will collect specimens, and now this specimen collection and registry is more than 1,000 patients. And of course, we need to educate. So we organized the first conference on inflammatory breast cancer. This still at this time goes every 2 years. And there is an inflammatory breast cancer international consortium where different institutions contribute. And of course, the clinic are now Dana-Farber also, Duke, in other centers recognize that model is obviously important for a disease that is more aggressive. Still, the breast medical oncology community has difficulty in recognizing that this is it's not just an advanced cancer, it's a more aggressive locally advanced breast cancer. No lump. We have 2 or 3 advocacy organizations that try to educate the community. It's certainly an international need. We have also outreach in North Africa, where it was first reported, and we're going to have a conference in May in Tunisia. Tunisia, like North Africa countries in general, are difficult to access even standard drugs. In Morocco, there is no access to Herceptin, you can imagine. When you talk about resources, these women have later diagnosis, even more than what you see with IBC diagnosis in the US and the Western country. It's certainly not the choices of treatment that we can offer to our patients. And of course, the other things is that we learned over 10, 15 years, we need to be aggressive in monitoring, in imaging, providing the best possible care, molecular. There is actually an overlap between the lipid biopsy research, in a way, and the inflammatory research. You want to monitor someone after primary therapy, you have to monitor the most aggressive form of cancer. So monitor inflammatory breast cancer makes perfect sense. And while I was working on IBC and after CTC, we started with cell-free DNA because clearly technology is evolving. And you can really detect small trace of cancer with the current available technology for cell-free DNA. So, but most important, you start to define how an aggressive disease becomes molecularly unstable and needs to be targeted after standard therapy. How this evolution is probably the most important mechanism resistant to treatments. And even under the pressure of treatments, you can have a more aggressive disease overall. And some disease doesn't progress that way, and we still don't know why. But I'm sure we will figure out that there is a correlation between cancer and immune factors, particularly the T lymphocyte and B cells. And then moving backwards, can we detect cancer before have as a recurrence? Can we detect cancer simply by a blood test as a complementary to mammograms and MRI, particularly in high-risk populations like BRCA1 and 2, where mammogram and MRI may not be sensitive? So can we change the way we actually practice? Today, oncology, in general medicine, when you have some disease for which there is no early detection and no screening, when I talk about this topic, I always try to address to a global scale. And the global scale means the cost of care. You cannot cure patients with advanced disease. In underserved countries will never have the resources to do screening on a larger scale. They will not have access to the drug that we have. And when you look at the statistic for breast cancer, for example, the largest population of breast cancer patients come from Asia. I mean, you think about India, China, we will never affect survival unless we focus all the efforts in screening and early detection. So we start with the CTC, inflammatory breast cancer, refining technology in liquid biopsy, and of course, along with drug development, but more drug development directed to provide personalized therapies. We should not give the same treatment to everyone expecting the same benefit. We need to understand exactly what our patient needs, especially when you have access to multiple drugs and targeted therapy. And then the screening part. So I want to end my career with something that really impacts survival in a significant way. And this means, obviously, screening and early detection. Then I will have fulfilled my mission.
That's profound. And you've covered most of what I was going to ask in a snippet, but a couple of points I wanted to bring out. Landing in the US in the 90s, probably without Google, kudos to that. It would have been a very different New York City to what it is today. And the other sort of comment, and I know this is, we want you to talk, not me, sorry, Michael, is that we were at a conference last week, Michael and I, and they're actually talking about this idea of precision oncology, that maybe people need to subspecialize in this area as opposed to being, you're the general oncologist and you're looking at a raft of mutations, having someone who's like tumor molecular boards, but on a larger scale where you are that expert. That was just a hypothesis of someone. And I thought that's an interesting point. We want to sort of focus on inflammatory breast cancer, but before I get there, I did want to talk to you about sort of the liquid biopsies and sort of ctDNA, specifically in where we're at the moment. So, you've spent 20 plus, maybe 30 years building this, which is incredible. Grandfather of liquid biopsy, ctDNA. Thank you, father. Thank you for sitting here. Where do you see it now in the utility of metastatic breast cancer? And yes, you mentioned what we sort of wanted for the future, but what do you see as the barriers to us getting to that point where, it's financially viable, but as the point I always ask when these private companies come to me, it's like, what do I do with this information? How do I implement this to save costs and make sure the patient's well and stays well?
There are very good points. First of all, the clinical utility. And for us, the clinical utility is to use the information in a way that improves patient outcome. That will be always dependent or very closely related to the access to drugs in metastatic setting. If I have a very specific mutation, I need to have the drug to target that mutation. And if the drug is available in some countries, not in others, then of course we have not an equal access to care. The other thing is that sometimes people think that one liquid biopsy is just a substitution to the tissue biopsy, but that's not the case. Simple speaking, this is tissue you biopsy a small area. With liquid biopsy, you get an understanding of the variability of biology from different sites of recurrence. The second, the liquid biopsy is a longitudinal natural history of the disease and evolution of the disease. You can never get that with tissue biopsy. So we are talking about refining our understanding of the disease and refining the way we approach the disease. Of course, there is a cost associated with that. But the technology is evolving. And as you know, every technology will be able to reduce the cost. I mean, think about the iPhone, how many versions of iPhone we have. So this is going to change very quickly. I'm working very close with some of these companies because they understand that they need to work for us to define what the technology needs to tell us. So for example, I may be able to come up with a test that is telling me how much tumor I have, what type of mutation we have, how is this evolving. The most important in our disease, the breast cancer, with subtypes, is now taking over. So that this will completely change the way we think about treatment. Right now in breast cancer, we think first line, second line, third line, refractory disease. But that's not for everyone. It's not always the case, and especially for estrogen positive patients, there is a lot of variability along the way. And then another important point, I think, how do we train the future generation? This should be part of their routine. We don't have an oncologist that does chemotherapy, and then we have a specialist that interpret the test, because that will be never bringing us anywhere. The medical oncologist needs to be trained very early on as part of their curriculum to the molecular testing, the interpretation, the application, no matter what they practice. They may have access or not, understanding the importance of this technology, in general, the importance of molecular medicine. And then everybody's talking about AI. So I think more data we build with clinical annotation about what happens when this patient will be treated in a certain way. Then we build algorithm, we don't need to spend that much money for every test. We're going to be able to direct our treatment because we know that certain patient with certain profile will respond to a specific treatment. This is the way we should arrange our medical schools. The earlier, the better. The fellowship programs, and of course, do more educational, but also work with the companies. I think the diagnostic company and the therapeutic, the industry needs to work together because that's the way we actually evolve and change oncology.
To hear you describe it and how liquid biopsies fit into the overlying order and architecture of things in the treatment of breast cancer, it's almost elegant the way you describe it in terms of getting that longitudinal information. And everyone who's listening who's ever had any involvement in breast cancer will know how heterogeneous, how tricky breast cancer can be and how quickly it can change. You mentioned with estrogen positive breast cancers, losing that estrogen positivity and becoming a completely different disease. However, we would like to, as Josh mentioned, focus on your particular area of expertise, which is the boogeyman of breast cancer, the type that strikes fear.
Maybe boogie woman.
Boogie woman,
Is that
yeah.
better, more appropriate?
Or
Majority of the time.
Yeah, exactly. But even for a oncologist that doesn't have a huge background in breast cancer, you hear inflammatory breast cancer. And even if you have no idea what that means, it just makes you shiver a little bit. So Massimo, can you tell us in very, very simple terms, compress your vast knowledge and tell us sort of what it is, what makes it so different and so scary as a disease entity, and what makes it different from, I don't want to say garden variety because breast cancer is 20 different conditions in one, but what makes it different from other types of breast cancer that it needs a specialist sort of clinic for research and treatment?
One of the center point is always been the diagnosis, the recognition. As you can imagine, these women do not have cancer yet. So one day they present with a very quick onset of swollen breast, erythema, pudorance, what you described, and a large breast. And invariably, and that's what we discover in our registry and the questionnaires, all of them go to the primary physician and then eventually GYN and receive antibiotics, thinking that they could have a mastitis. Now, there is no fever. They're not lactating 90% of the time. So why they should be treated as a mastitis? The next step, and this may take a few weeks, or sometimes longer, someone decided they need an imaging, breast imaging. So they do a mammogram that usually show just simply some thickness of the skin. Eventually they go to an MRI, an ultrasound, and they start to see a more complex picture. And by the way, these women already have lymphanodal disease.
I was going to say this is something that moves at a rate of knots,
Yeah.
so that's not weeks that they usually have.
So there is no early inflammatory breast cancer. There is a stage 3 or stage 4 inflammatory breast cancer with lymphanodal disease. By that time you go to biopsy, you show that, in fact, this swollen breast is actually an invasive disease that has already blocked the lymphatics. So we put a lot of effort in really trying to understand why the breast is so large. It's not because of the tumor blocks the lymphatics. You may know surgeons want to really prove that there is a tumor in the skin and start to do skin biopsy. You don't need that because the tumor in the skin skips area. So if you put a small needle, a small punch, you're not going to be able to find it. You're just delaying the intervention. And then you get to the PET, and the PET one is really interesting because it starts to show the highly metabolic tumor within the breast, the skin that is obviously hypermetabolic, and the extensive lymphadenopathy. You can have lymphadenopathy in the internal mammary, infraclavicular, axillary region, sometimes in the contrarata. And the PET showed that 40% of these patients are already metastatic. And that brings a lot of confusion because do we treat metastatic disease as an aggressive tumor or we treat metastatic as a palliative? You don't want to treat an aggressive inflammatory breast cancer metastatic as a palliative treatment. This will get out of control very quickly. So once you have identified, obviously all these patients inoperable needs to be started with neoadjuvant treatment. Chemotherapy combination, chemotherapy, hormone therapy, immunotherapy, depends on the subtype. That's where we have a problem already. There is no specific therapy that is different from disease subtypes therapy, right? So this patient may or may not respond. Obviously, they have to target the therapy to a better job. If you don't have a complete disappearance of the tumor, you have a very high chance of recurrence. If you don't have a response, and you do have skin changes persistent, you should not go to surgery because you have difficult to clear margins. We have seen over the years, when disease is treated as a local advanced non-inflammatory, there is a salvage surgery. That's the beginning of the disaster, because this patient had immediate recurrence on the chest wall, and that spread all over, and it becomes very painful. The other aspect is the human aspect of the disease. When there is a recurrence, these women will leave with their chest wall recurrence. They spread all the way, opposite side, then start to reach out to the pleura. Then you have a pleural fluid. And when you have pleural fluid, you get to the lungs. It can be extended period of time where the disease is still on the chest wall, painful. And that's the unique aspect of IBC, the lymphatic spreading, not within the blood vessels, but the lymphatic spreading. You see this extensive chest wall recurrence before you get to the organs. So patients suffer before they get visceral disease. And 25% of them get brain metastasis in the natural history of the evolution. So we know exactly how this disease behaves. We published several papers on that. So we monitor the brain. We try to not to go to surgery when the patient does not respond. We try to introduce radiation therapy. But the bottom line is that this lymphatic spreading, I believe after so many years that is not much the cells that are different, but it's the patient's immune dysfunction or some aspect of this patient's immune defense that is actually contributing to the way these cancer cells are together in this emboli and spread to the lymphatics. And if we don't shift that thinking, we'll not be able to really treat or understand IBC completely.
Yeah, it's interesting. It's there's not many cancers you sort of diagnose and all of a sudden you're like, I must treat this, extensively or very, very quickly. And also, I'm just making my little anecdotal comments every time you finish talking, but I think as early career oncologists, we're lucky enough that we probably haven't seen the historic days or the bad days of, lots of people just dying in these Nightingale wards with extensive cancer from, World War II. My father was an orderly back in the 60s. Never wanted to do anything in medicine after that, but I think it was essentially like a repatriation hospital where everyone was dying of cancer. And it's just horrific. And it's reminiscent of those sorts of diseases. So you've got your patient, you've got your diagnosis of inflammatory breast, you've educated everyone. The world knows now. What's your approach? So you give them therapy to try and sort of cut this out, essentially. You get them to respond, you cut it out. And then what, do you give them more therapy? Like, how do you sort of manage this? Because with most of the treatments and the trials we do don't have a large inflammatory breast component. So we don't exactly know, the role of CDKs, anthracyclines, all these sorts of things. How do you sort of bring those two together?
Yeah, so obviously we try to give the treatment that have been for disease subtypes, breast cancer, but you're right. When we actually went back to investigate how many patients with immunotherapy were in the clinical trial that brought to the approval, there were only 4 patients. So we are making assumptions that in fact immunotherapy worked with a chemotherapy combination, pembro, for patients with inflammatory breast cancer, but we don't have the data. In the real world, I would say we have patients treated with this combination do not respond as well as the standard breast cancer. So there is some sort of dysfunction of the T cells component in this disease for which the pathological response that was reported for the triple negative, non-inflammatory, locally advanced or stage 2 or stage 3 is different. That's why in the post-surgery, post-radiation, by the way, the radiation is always a higher dose than what you use for regular breast cancer, and this patient always get mastectomy with axillary dissection, no reconstruction. In the post-treat, you need to do some form of treatment. There is always adjuvant and not just watching. But there is also watching. I mentioned at the beginning the MRD testing. So you need to watch, you need to treat, you need to develop other possibly targeted therapy in the adjuvant setting. For right now, yes, we do pembro, we do chemotherapy, we try to put patients in the clinical trial with the new antibody drug conjugate. We use CDK4/6 inhibitors for the ER positive, hoping that all of this will slow down possible recurrence. Many times it doesn't, but when it does, of course, we hope that they will last. Now, this aggressive disease. Of course, it doesn't occur in the first 2 or 3 years, probably you are cured. So we need to really achieve full monitoring, treatment, and coverage, including, as I mentioned, brain MRI this is one of the sanctuary sites where, unfortunately, we're not able to control as much as possible very early on in the first 2 or 3 years. All the studies that were done with the MD Anderson database show the extensive risk of recurrence, particularly in the lymph node, in the soft tissue, in the chest wall, in the pleura after the chest wall, in the brain. So it's predictable. I think you can understand how this disease is going to be when you follow these patients, a number of patients for a long time, and we will need to implement this measure. But most important, as I say, we need to study the patients more than the tumor at this point. All these patients have something in common. One easy thing to say that what the epidemiological studies suggest, for example, that obesity is associated with inflammatory. It's just a simple association, or it's something to do with immune dysfunction, metabolic syndrome, or other factors that we haven't investigated. So this is something that needs still to be studied. And I hope there will be more and more oncologists and clinicians, researchers that are invested in clarify this is deadly disease. It's like the leukemia of breast cancer, I say. We need to do something about it.
One last question before we give our traditional ending question. You are uniquely placed to sort of talk about the future for inflammatory breast cancer. You've mentioned extensively how different it is from non-inflammatory breast cancer. In your mind, as one of the preeminent experts across the globe, where do you see the future treatment for inflammatory breast cancer? Is there anything in your research that has caught your eye or that you think might have promise as a novel treatment for inflammatory breast cancer, more so than non-inflammatory?
Yeah, I mean, there are some targeted therapy that are possibly more effective in inflammatory or not. And when we talk about in the liquid biopsy and NGS studies, we show that, for example, some of the mutations and alterations on genomic level are more frequent. We see more PI3K mutation, F3 mutations. So it's possible for some of these patients, the current targeted therapy may represent a way to treat and maybe even to design some intervention for prevention, so some adjuvant intervention. So that's in terms of molecular testing. Then in terms of immunotherapy, we notice, for example, B-cell dysfunctions in a good number of IBC patients. So how we can restore immune function. And I think this is something we need to probably look into lymphoma research or other diseases to figure out exactly how some of these drugs maybe can be repurposed for inflammatory breast cancer. It certainly is not a typical breast cancer treatment, but we need to think out of the box based on the observation and the data we can generate to see if we can change the paradigm and a shift in what we utilize right now for treatment.
Michael and I have a tradition on this show as we sort of finish up with our experts. But the final question, and probably the hardest one, I think, is if you could give your younger self some advice, whether that be professional or personal, what would it be? What pearls of wisdom do you wish you had known 35 years ago when you had started this journey? You'd started, you'd moved across the globe, you were starting your preeminent research and, you've got 400 plus papers and you've collaborated with people all over the world. And I'm sure you've met incredibly inspiring individuals, but what's the one thing you wish you'd known?
If you want to have success in life, you need to bring your network, support network, a good mentorship. Sometimes I was missing that mentorship. So I had to reinvent myself each time and try to find the support as I go, but without having really that mentorship. So to my youngest version, but also to the junior faculty that I mentor right now, I say you really need to find, first of all, your passion, then your mentorship, then your network, and be focused. One thing that obviously, as you heard from me, I'm not being focused because I really wanted to go in one direction, but then I had other interests. So IBC, liquid biopsy, drug development, it takes a lot of energy. Sometimes in terms of a career, you're more successful if you focus on one area and then, obviously people recognize for that. IBC is not the most popular topic, so certainly may not help in your career, even though it helps me to feel good about something that eventually one day hopefully will be resolved. Same thing for liquid biopsy 20 years ago. It was nothing and people are still have some doubts where, but it's going to spill over everywhere. And I think, these are difficult. When you have work in an area where there is shifting in thinking, changing in approach to medicine or any other area. It's very unlikely you'll be recognized right away because people are not ready for it. That's important for the younger me. Try to find something easier and pursue that and get focused. I think I'm satisfied with what I've done.
Everyone outside you, Massimo, is incredibly impressed and awestruck. Wise words in an episode laden with wisdom. Thank you so much for coming on. Absolutely wonderful to have you and hear you speak about your many, many passions.
Thank you. Thank you so much.
Thank you for listening to this episode of Oncology for the Inquisitive Mind, produced by ADC Productions with the assistance of education grants from Pfizer, Gilead Pharmaceuticals, and Merck Pharmaceuticals. As always, these companies do not receive early previews or editorial input of any kind. The opinions expressed in this episode are our own, and the facts are, well, the facts. If you liked this episode, please consider subscribing to be among the first to hear our latest forays into the ever-changing world of medical oncology. You can find previous episodes of our show, including coverage of major conferences, interviews with world-renowned experts, and much more at inquisitiveonc.com. If you would like a particular subject covered on the show, drop us a line at inquisitiveonc@gmail.com. And if you happen to be in Australia, stay tuned for details about exciting in-person events we have planned for the near future. Thanks for listening, and we look forward to demystifying oncology again next time.